So welcome everyone to this discussion that we're going to have right now. My name is Noelle Marshall. My husband, Bob Warner, Light Partners. We are bringing another edition of Racial Equity and Social Justice Challenge. And today we're going to focus on public health. Yesterday we focused on voting, and that was a very powerful hour that Bob brought for us. Now we're inspired by all of this by the YWCA 21-day challenge. And Bob is going to put in the chat all the links because this is really going to be a picture show, because we're going to watch many videos because this issue is so vast. What happens to public health as we deal with racism in this country? 21-day racial equity and social justice challenge. So you can go to the YWCAKNOX.com/21-day challenge sign up. And Bob will be putting that in the chat as well. This is a free thing that you can do, and you can take your time. You just sign up, and they have different topics every week. And the topics that we are doing are related to voting, public health, how racism affects public health, also how it affects the criminal justice system, and education. And we'll be talking about education tomorrow. So now let me begin our first share. And I'm going to go to this video here. We're going to watch a lot of videos because instead of me talking a lot, I just want to be able to impart the most information that we can about this subject. So here is a brief little thing about reversing runaway inequality, social capitalism.
To understand economic inequality in our society today, we need to understand how it was built many years ago on racism. Wall Street, you know it as the finance capital of the world, but did you know that Wall Street was first famous for being a key stop on the transatlantic slave trade? That's right. The financial capital of the United States was actually a trading post for enslaved men and women. By the mid-1700s, New York City had one of the largest populations of enslaved people in North America, with about 40% of white households owning at least one enslaved person. Buying and selling enslaved people was essential to setting up some of the future success of today's Wall Street banks. They built their fortunes by loaning money to owners of enslaved people. If those owners couldn't pay back their loans, the enslaved people became legal property of the banks. That's how some of today's biggest and most powerful banks, like J.P. Morgan Chase and Bank of America, got their start. Since the very beginnings of our country, two ideas, racism and free market capitalism, have worked together to shape both how our society works and government policies. Together, racism and capitalism have formed the basis of so much of what we experience today. The two ideas are so deeply connected and such a big part of our daily lives that we have to think of them together if we're going to understand the problems we're facing. Instead of thinking about racism and capitalism separately, we're going to think about them as one connected system called racial capitalism. The system of racial capitalism allows the rich and powerful to take wealth from poor and working class communities, especially communities of color. The rich and powerful keep taking more power and concentrating more wealth. We see it in housing. Decades of discriminatory law practices, known as redlining, have kept people of color from buying homes in white neighborhoods. These policies have prevented people of color from building wealth, allowing more and more money to concentrate in white communities. In recent years, dozens of major banks, including Wells Fargo, TD Bank, and Capital One, have been sued for basing their lending decisions on skin color. Black and brown borrowers are nearly twice as likely to be given high-interest mortgages compared to white borrowers with similar incomes and credit histories. We see it in air and water quality. People of color are more likely to be exposed to pollution than their white neighbors. Big corporations have made it a common practice to put major sources of pollution, like landfills and incinerators, in Black and brown neighborhoods. These cause higher rates of asthma, heart disease, and cancer. We see it in education. Chronic underfunding of our public schools has hit communities of color the hardest. Schools have closed, classroom sizes have ballooned, and arts and music programs have been cut. Wealthy investors looking to make a quick buck opened for-profit charter schools in low-income neighborhoods. Education has become a billion-dollar business, and Black and brown students are the ones paying the price. The average Black family would need to toil away for 228 years to amass the wealth of a white family today. Racial inequality is woven into the fabric of our economy, and an economic system that profits off racism takes a serious human toll in the form of mass incarceration and over-policing. To challenge one broken system, the other must be addressed as well. Only by dismantling racial capitalism can we begin to repair the deep harm done to our communities and create a society that works for all of us.
Hi, and welcome to this video on the social determinants of health. This is a very important concept to understand because its impact on the health of individuals and of populations. We'll be taking a look at what it is, how it impacts health, and a useful framework to understand it. Take a look around you, your family, friends, and other people around you. What's clear is that health is quite variable, not just between individuals, but also across different population groups. Let's take an example. In 2015, the life expectancy of a child born in Sierra Leone was 50 years, whereas in Australia it was 83 years, a difference of 33 years. But there are differences even within countries. For example, in Australia, the life expectancy of Indigenous people is about 10 years lower than that of non-Indigenous people. Within a population, health is also influenced by social status. People with higher income, a higher level of education, and a better occupation have better health and a greater life expectancy. Health status can change as well. For example, studies of migrants have shown that the type of diseases, health behaviors, and risk factors are different in migrants compared to those in their country of origin. So why is there so much variability? To answer that question, we must understand the factors that can influence health. Let's have a look. A person's health is influenced by a range of factors called determinants of health. These include who they are, individual factors such as age, sex, and genetic makeup, and also what they do. This includes their health behaviors such as smoking, physical activity, alcohol use, and diet. Health is also largely influenced by the conditions in which people are born, grow, live, work, and age. These include their social and community networks, the socioeconomic, cultural, and environmental conditions that people live in, and also health systems. These are collectively called the social determinants of health. The social determinants of health are ultimately shaped by the distribution of money, power, and resources at an international, national, and local level. They have a marked influence on health inequities, which is the unfair and avoidable health differences between different groups of people within countries or between countries. Now, there are many different social determinants of health, working across many levels and with complex interactions between them. So, to understand and explain how these determinants influence and interact with each other to affect health and well-being, several models or frameworks have been proposed. There are many different frameworks that do this, but let's have a look at one useful framework developed by the World Health Organization. According to this framework, there are two broad types of health determinants that influence health and can lead to health inequities. These are structural determinants and intermediary determinants. Structural determinants refer to the socioeconomic and political context in which a person is born into and lives in. These include governance, how society organizes itself to make and implement decisions, economic, social, and public policies, and also the social and cultural values that communities place on health. These factors can determine and lead to the unequal distribution of material and monetary resources, which shapes a person's socioeconomic position. The socioeconomic position describes a person's place in society, which can affect their exposure, vulnerability, and outcomes to conditions that have an impact on their health. The socioeconomic position is determined by a number of factors such as education, occupation, income, gender, race or ethnicity, and social class. The socioeconomic position in turn affects the intermediary determinants of health. These include material circumstances, like the quality of housing, the financial means to buy healthy food, clothing, or other requirements for healthy living, and also the work environment. Psychosocial circumstances, like stressful living circumstances, relationships, and social support. Behavioral and biological circumstances. In addition to these, health systems have an impact on the type and quality of healthcare available to people. It also determines how easy it is for people to access health services and receive the healthcare they need. Social cohesion and social capital are factors that bridge the structural and intermediary determinants. They describe the willingness of people living in a community to make sacrifices and to cooperate with each other for a wider benefit. Intermediary determinants influence health and health inequities. It's also important to know that the links between these different factors are not always linear, but are complex and can go in both directions. For example, poor income and education can impact health, and also, poor health can limit opportunities for people to participate in the workforce or receive education. Also, if population is affected by a lot of disease, it can have a broader impact on the socioeconomic and political context. So how can we change or influence these determinants? Addressing the social determinants of health is not an easy task. It involves identifying the structural and intermediate determinants of health and taking appropriate actions to improve them. To do this requires actions across all sectors of society and at all levels, including local, national, and international. The actions will depend on the existing socioeconomic and political context, resources that are available, and commitment for action. And that's a quick introduction to the social determinants of health. We've had a look at what it is, how it impacts health, and a useful framework to understand it.
So I hope you enjoyed that. And we're going to continue on with this education process. And I'm going to now change to another video. And we're just bringing in the experts here. So this one is a lot shorter, but it gets more closer to the issue. This is an emergency room doctor talking about how our healthcare is determined by systemic racism.
Compared to white Americans, Black Americans die prematurely from all types of diseases. George Floyd, Trayvon Martin, Ahmaud Arbery. These have all become household names, but for all of the wrong reasons. Hearing about a Black man being shot by law enforcement in the United States has unfortunately become the norm. What cell phone cameras and surveillance footage fail to capture are the injustices spread out across all the various sectors of our society. As an emergency medicine physician, I practice in facts, and the fact is that compared to white Americans, Black Americans die prematurely from all types of diseases, including diabetes, hypertension, strokes, and of course COVID-19. A recent study by Cigna found higher rates of childhood obesity, cancer, diabetes, and heart disease amongst Blacks, linked to the lack of economic resources, limited access to care, delay in treatment, and lower health literacy rates. Even when all the variables like location, age, and economic status are accounted for, Black Americans die at a quicker and faster rate in our healthcare systems compared to white Americans. Black newborns die 250% more often than white Americans in our country. Black Americans between the ages of 18 and 49 are twice as likely to die from heart disease than whites. You have chest pain, you show up to the emergency department. Well, if you're Black, you're going to be waiting longer for that life-saving initial EKG. Black men are 50% more likely to get prostate cancer and 200% more likely to die from that prostate cancer. These trends hold true for diabetes, hypertension, strokes, and so many other diseases across the spectrum. Many physicians have preconceived notions leading them to believe minority patients won't comply with medical recommendations such as incorporating exercise, and the biases extend to other minority groups like Asians and Hispanic Americans. Senator Cory Booker recently highlighted that Black mothers are 3 times as likely to die from complications related to pregnancy compared to white mothers. Recently, Dr. Anthony Fauci was quoted as saying, "The COVID-19 pandemic has shined a bright light on how unacceptable the healthcare disparities are in our country." Conditions such as diabetes, hypertension, and asthma that tend to plague minority groups at a higher rate than other groups likely contribute to the higher COVID-19 death rate. Nationally, African American deaths from COVID-19 are nearly 2 times greater than what would be expected based on their share of the population. From physicians to police officers and politicians, we need to stop and reassess who we are as a country and who we want to be.
So I hope you see that I've been trying to build a story here that if we want to fix the injustices in our healthcare system, that the roots go very, very deep, and it's very tragic. But I don't want you to think that we don't have solutions. Now we're going to have another talk here, a TED Talk by a very distinguished doctor. And he's also going to, the next 2 talks are going to be talking about some solutions.
An article in the Yale Alumni Magazine told the story of Clyde Murphy, a Black man who was a member of the class of 1970. Clyde was a success story. After Yale and a law degree from Columbia, Clyde spent the next 30 years as one of America's top civil rights lawyers. He was also a great husband and father. But despite his success, personally and professionally, Clyde's story had a sad ending. In 2010, at the age of 62, Clyde died from a blood clot in his lung. Clyde's experience was not unique. Many of his Black classmates from Yale also died young. In fact, the magazine article indicated that 41 years after graduation from Yale, the Black members of the class of 1970 had a death rate that was 3 times higher than that of the average class member. It's stunning. America has recently awakened to a steady drumbeat of unarmed Black men being shot by the police. What is even a bigger story is that every 7 minutes, a Black person dies prematurely in the United States. That is, over 200 Black people die every single day who would not die if the health of Blacks and whites were equal. For the last 25 years, I have been on a mission to understand why does race matter so profoundly for health. When I started my career, many believed that it was simply about racial differences in income and education. I discovered that while economic status matters for health, there is more to the story. So for example, if we look at life expectancy at age 25, at age 25, there's a 5-year gap between Blacks and whites. And the gap by education for both whites and Blacks is even larger than the racial gap. At the same time, at every level of education, whites live longer than blacks. So whites who are high school dropouts live 3.4 years longer than their black counterparts. And the gap is even larger among college graduates. Most surprising of all, whites who have graduated from high school live longer than blacks with a college degree or more education. So why does race matter so profoundly for health? What else is it beyond education and income that might matter? In the early 1990s, I was asked to review a new book on the health of Black America. I was struck that almost every single one of its 25 chapters said that racism was a factor that was hurting the health of blacks. All of these researchers were stating that racism was a factor adversely impacting blacks, but they provided no evidence. For me, that was not good enough. A few months later, I was speaking at a conference in Washington, D.C., and I said that one of the priorities for research was to document the ways in which racism affected health. A white gentleman stood in the audience and said that while he agreed with me that racism was important, we could never measure racism. We measure self-esteem, I said. There's no reason why we can't measure racism if we put our minds to it. And so I put my mind to it and developed 3 scales. The first one captured major experiences of discrimination, like being unfairly fired or being unfairly stopped by the police. But discrimination also occurs in more minor and subtle experiences. And so my second scale, called the Everyday Discrimination Scale, captures 9 items that captures experiences like you're treated with less courtesy than others, you receive poorer service than others in restaurants or stores, or people act as if they're afraid of you. This scale captures ways in which the dignity and the respect of people whose society does not value is chipped away on a daily basis. Research has found that higher levels of discrimination are associated with the elevated risk of a broad range of diseases, from blood pressure to abdominal obesity to breast cancer to heart disease and even premature mortality. Strikingly, some of the effects are observed at a very young age. For example, a study of Black teens found that those who reported higher levels of discrimination as teenagers had higher levels of stress hormones, of blood pressure, and of weight at age 20. However, the stress of discrimination is only one aspect. Discrimination and racism also matters in other profound ways for health. For example, there's discrimination in medical care. In 1999, the National Academy of Medicine asked me to serve on a committee that concluded based on the scientific evidence that blacks and other minorities receive poorer quality care than whites. This was true for all kinds of medical treatment, from the most simple to the most technologically sophisticated. One explanation for this pattern was a phenomenon that's called implicit bias or unconscious discrimination. Research for decades by social psychologists indicate that if you hold a negative stereotype about a group in your subconscious mind, and you meet someone from that group, you will discriminate against that person. You will treat them differently. It's an unconscious process. It's an automatic process. It is a subtle process, but it's normal, and it occurs even among the most well-intentioned individuals. But the deeper that I delved into the health impact of racism, the more insidious the effects became. There is institutional discrimination, which refers to discrimination that exists in the processes of social institutions. Residential segregation by race, which has led to blacks and whites living in very different neighborhood contexts, is a classic example of institutional racism. One of America's best kept secrets is how residential segregation is the secret source that creates racial inequality in the United States. In America, where you live determines your access to opportunities in education, in employment, in housing, and even in access to medical care. One study of the 171 largest cities in the United States concluded that there is not even one city where whites live under equal conditions to blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. Another study found that if you could eliminate statistically residential segregation, you would completely erase black-white differences in income, education, and unemployment, and reduce black-white differences in single motherhood by 2/3. All of that driven by segregation. I have also learned how the negative stereotypes and images of blacks in our culture literally create and sustain both institutional and individual discrimination. A group of researchers have put together a database that contains the books, magazines, and articles that the average college-educated American would read over their lifetime. It allows us to look within this database and see how Americans have seen words paired together as they grew up in this society. So when the word black appears in American culture, what co-occurs with it? Poor, violent, religious, lazy, cheerful, dangerous. When white occurs, the frequently co-occurring words are wealthy, progressive, conventional, stubborn, successful, educated. So when a police officer overreacts when he sees an unarmed black male and perceives him to be violent and dangerous, we are not necessarily dealing with an inherently bad cop. We may be simply viewing a normal American who is reflecting what he has been exposed to as a result of being raised in this society. From my own experience, I believe that your race does not have to be a determinant of your destiny. I migrated to the United States from the Caribbean island of St. Lucia in the late 1970s in pursuit of higher education. And in the last 40 years, I have done well. I've had a supportive family, I have worked hard, I have done well. But it took more for me to be successful. I received a minority fellowship from the University of Michigan. Yes, I am an affirmative action baby. Without affirmative action, I would not be here. But in the last 40 years, Black America has been less successful than I have. In 1978, Black households in the United States earned 59 cents for every dollar of income whites earned. In 2015, Black families still earn 59 cents for every dollar of income that white families receive. And the racial gaps in wealth are even more stunning. For every dollar of wealth that whites have, Black families have 6 pennies and Latinos have 7 pennies. The fact is, racism is producing a truly rigged system that is systematically disadvantaging some racial groups in the United States. To paraphrase Plato, there is nothing so unfair as the equal treatment of unequal people. And that's why I am committed to working to dismantling racism. I deeply appreciate the fact that I am standing on the shoulders of those who have sacrificed even their lives to open the doors that I have walked through. I want to ensure that those doors remain open and that everyone can walk through those doors.
This is another doctor who is going to talk to us, and she's going to introduce the idea of combating racism and placism in medicine, as well as how to use technology, so to be more of a problem solver. So here we go.
The medical profession may be doing harm to patients and communities. Many years ago, as a first-year medical student, I took an oath, like thousands of physicians before me and thousands of physicians after me, that I would first do no harm to the patients and the communities that I serve. And since then, I have committed my career for taking care of patients in underserved communities, just like this one on the Near East Side of Columbus, Ohio. But over time, I've seen that the medical profession has broken that social contract with the communities that we serve because of racism and placism. Now, this is going to be best illustrated if I walk you through the lives of two of my dear friends. So first, let me tell you who they are. Many years ago, as a young, aspiring physician, new to practice, I started my career off in Connecticut, where I had the good fortune of meeting two wonderful women who would become lifelong friends and honestly like family. And it is through their lenses that I will walk you through the impact of racism and placism in medicine. So first, I want you to meet Wendy. Wendy's a Black woman. I met Wendy as a middle-aged mother, hardworking woman, working so hard to provide for her kids. Through my relationship with Wendy, I've learned so much about tenacity, grit, and honesty. I also want you to meet Sarah. Sarah's a white woman. I also met her as a middle-aged woman, a mother, hardworking, did so much to provide for her family as well. And through my friendship with Sarah, I've learned so much about allyship and loyalty. Now, when I met Wendy and Sarah, they lived about 6 miles apart in central Connecticut. Sarah in the wealthier suburbs outside of West Hartford, and Wendy in the inner city outside of East Hartford. Although they only lived 6 miles apart, their potential interactions with the healthcare system could not have been any more different because of racism and placism. So let's talk about what those mean and what those look like in medicine. Racism in medicine means that Wendy, as a Black woman, would be much less likely to have positive interactions with the healthcare system, much less likely to be taken seriously by doctors, and much less likely to have state-of-the-art healthcare wherever she lived. Because in medical school, we are taught that Black patients have a higher threshold for pain. If Wendy came to my office presenting with pain, as a Black woman, she would be significantly less likely to have that pain addressed. Similarly, if Wendy, as a Black woman, presented to the emergency department with crushing chest pain, she would be 50% less likely to receive any life-saving intervention for a heart attack. Now, in medicine and in nursing, we're often taught to discount and discredit the symptoms of Black women. So if Wendy, as a Black woman, went through her pregnancy, she would be 3 to 4 times as likely to die in that pregnancy or in the childbirth than Sarah would as a white woman. Similarly, if Wendy gave birth to a baby, she would be twice as likely to bury her baby before the age of 1 than Sarah would as a white woman. And if Wendy gave birth to a Black baby and that baby was taken care of by a white physician, that baby would have an increased risk of dying in that first year. Racism in medicine also means that although Wendy, as a Black woman, would be much less likely to be diagnosed with breast cancer or colon cancer, if she were diagnosed, she would be diagnosed with much more advanced disease, later stage disease, and have a 50% higher mortality than Sarah as a white woman. And so it's not really the phenotype of race, it's the structures of racism that would lead Wendy to toxic accumulation of stress that will lead her to earlier heart disease than Sarah. So racism is taking its toll in medicine. Now, the other issue is placism. And by placism, I mean the ignorance of a person's place, where they live, their zip code, on their health. We know that 80% of a person's health status is determined by social determinants of health, not their interaction with me as their doctor. The conditions where they live, work, play, school, housing, economic security, jobs, safety, violence. But chances are your doctor has looked at you and made a decision on how they will care for you based on your race, but they have never paid attention to your place or your zip code. So this shows up in significant health disparities in life expectancy. If you look at the state of Ohio, in green, you'll see the wealthier parts of the state. People have a life expectancy into their late 80s, almost into their 90s. Not too far from some of these same places in red, you see that people have a life expectancy in their 60s. So there can be a 29-year difference in your life expectancy based on where you live. Now, if we zoom in on where I am right now in Central Ohio, the life expectancy challenges are the same. You can see places that are not that far away have over 27 years of a difference in life expectancy between the poorer and the wealthier zip codes. Where I'm standing right now on the Near East side of Columbus, Ohio, a mile away in a wealthier suburb of Bexley, people are expected to live 18 years longer than the people in the community that I'm standing in. Chances are, no matter where you are in the United States, these same health disparities exist. These same problems based on your place exist. So back to Wendy and Sarah. When I met Wendy and Sarah, they lived about 6 miles apart. But that meant that Sarah was expected to live to the age of 84, and Wendy to the age of 68, a 16-year difference based on 6 miles. So you may wonder, what if we just moved Wendy over to where Sarah lived? Would that change? Unfortunately, because racism would follow her, Wendy's life expectancy would not change. It would be as if Wendy lived in the same place for her whole life. And that is because racism is the father of placism. Placism is the derivative of racism. Structural housing discrimination, redlining, and many other structural factors have led to the reasons why people in certain communities have lower life expectancies. So how then can I have lifelong friendships with Wendy and Sarah? I want us all to live and have our relationships until we're in our 80s. This is where I believe that we can make a difference through changes in education and leveraging technology. So with education, we need to dismantle and deconstruct racist, oppressive, prejudicial, biased education that we provide to medical students, nursing students, and other health profession students. The same mythology and stereotypes that were used to justify slavery are still used in medicine today. We need to dismantle and deconstruct that sort of education and instead replace it with anti-racist, anti-oppressive, scientifically focused, stereotype-free, and informed care that allows us to give equitable care to our patients. But what do we do then if we change the educational system? We know educational reform takes a long time. What do we do about the thousands and thousands of physicians like me who are not going back to school anytime soon, but they have been unfortunately indoctrinated with these awful stereotypes and beliefs about their patients? This is where I believe the second solution can help us. Technology can help us be anti-racist and anti-placist. So what might this look like? Chances are if you go to a doctor's office, they are using an electronic medical record where they're collecting so much information about you. And I believe that we can use clinical decision algorithms that will allow us to be anti-racist and anti-placist at the point of taking care of you. Because most doctors have looked at your race, but they have not asked about your place. So what would this look like in real life? Let's say a patient, Molly, came to my office. And in the course of care, which is customary, my medical assistant, before I see her, will collect her height, her weight, her blood pressure, and ask her about her pain on a scale of 0 to 10, with 0 being little pain and 10 being her worst pain. What if Molly said she had a 7 out of 10 pain, but as often happens to Black patients, I didn't pay attention to it? What if the technology could call that pain to my attention and stop me before I could do anything else in that electronic health record and say, studies tell us that Black women are much less likely to have their pain addressed. Are you sure you do not want to address Molly's pain? I could say, yes, I'm sure. I do not want to address her pain. I want to be racist. Or I could go back and I could do something different. Similarly, if I was not managing her high blood pressure with the top of the line agents. We know that Black patients often get the third or the fourth line agent for their hypertension. What if the technology stopped me here too and forced me to be anti-racist and reminded me that African American patients are much less likely to get prescribed first-line agents? Are you sure you do not want to change Molly's medication? I could say, yes, I'm sure. I want to continue to be racist, or I could go back and do something different. Same thing could apply to colon cancer screening if I did not screen my patient, as often happens to Black patients. The system could ask me, it could force that into my consciousness, it could force me to do no harm. What can we do about placism? So chances are we have not paid attention to your zip code, nor would we know what to do with it if we saw it. So what if we use community mapping tools and a lot of the geospatial imaging that we have to tell us about social determinants of health, not only your risk based on your zip code, but also what to do about it? What if the technology called out my patient's zip code and told me that she lived in this zip code where she's likely to die early from heart disease? Will you discuss heart health and disease prevention with your patient? I could say no, I want to continue to be placist, or I could go back and do something different. I believe we can do this. I believe we can turn the tide and renew that contract with medicine. But it's going to take patients, institutions, and doctors to all play their part. So patients, be empowered to ask more from your doctors. You have a right to full health. Ask us to address your pain. Ask us what screenings you should be having based on your age or your gender. Ask us if we were really on the first-line medications for your condition. But institutions, you also have a role. You need to retrain your doctors, your nurses, your health professionals. Deconstruct and reconstruct that educational model that you have. Teach your physicians, your nurses, your health professionals to see patients as whole people. Teach them to be humble, culturally empathetic, and to see their patients as their own. And finally, doctors, my peers, my colleagues, we took an oath. We promised our patients and our society that we would take care of them, that we would do no harm. Honor your oath and give patients the love and the care that they need. And together, we can give life, love, hope, and healing to the communities that we serve. And together, we can do no harm. Thank you.
That's a beautiful presentation, Combating Racism and Placism in Medicine by Dr. Nwando Olewola. And we do have the link to that if you'd like to get more information about that. And I think the way that she's using technology is very creative and very helpful for us in these times. So we've looked at two doctors who had ideas about how we can, where racism comes, why there's a disparity in our healthcare system. Now it seems that there are some advances, some breakthroughs in some areas. We're going to look at a very short video that the Washington Post put out. Lawmakers across the country declare racism as a public health crisis. So it is getting some attention as an issue. And so there's some good news there, because I always say you will have to be, it has to be revealed to be healed. So
it's important for it to be noted that the conversation that's happening nationally is a very important one, but the circumstances aren't new. Defund the police! No more pigs in our community! No more pigs in our community!
They walk to express to the nation in a peaceful fashion their rights.
We're traumatized just by the systemic fact that we've been under oppression for over 400 years. And though we may not be on the bottom of boats anymore, but we certainly at the bottom of education. We may not be in the cotton fields for free labor, but you're certainly getting it from us now.
It all just comes down to that we're in a state of emergency because Black people are dying.
Clearly, I have missed the boat in some way as an elected leader. I recognize that. I now need help fixing that.
This resolution affirms that racism is a public health crisis that results in disparities in family stability, health, and mental health wellness, education, employment, economic development, public safety, criminal justice, and housing.
All those in favor?
Aye.
16 yeas.
This will finally give some teeth to some things that we've been working on here in Milwaukee County for quite some time.
H9 0 notes. The item is received and placed on file.
When you make a declaration and you tell people this is a crisis under CDC guidelines, now you have to do whatever you can to mitigate the crisis. We look at this as racism being the other pandemic that we're experiencing right now.
And really felt we've come to a cultural and societal moment where it is just pivotal that we say collectively, racism exists, it's been wrong, it's wrong now, and we have to join together and do everything we can to eliminate it.
And it's unfortunate that an event and a circumstance such as George Floyd had to happen for them to shine even, a light or get a closer lens into what disparities are affecting Black Americans. If we do not address this moment now, Black people are going to continue to remain in that cycling of suffering.
What I brought to the table on this was, let's not just do a resolution, but let's have a plan for work after we pass it. And that's where I said, let's create an element group of the countywide vision to really dig into and work on the topic. And our shared goal is to identify, eliminate the effects, and prevent racism.
It was all 5 yeses and no nos. I was excited, but then right at that moment, I couldn't celebrate too hard because I said, there's still work to be done. There's still work to be done. This isn't just a resolution. This is on paper, but we got to make sure that there's actionable steps put into place. This cannot be performative.
And in the 53206 zip code is a zip code that's nationally known for being the most incarcerated in the world. Wisconsin has been named the worst state in the nation to raise a Black child. I think it only made sense that we were the first to declare this a public health crisis. I'm proud. We created a vision statement for the first time in 20 years. This hadn't been done in 20 years, and our vision is very simple. We want to make Milwaukee the healthiest county in the state of Wisconsin by achieving racial equity. And that's what led to our racial equity ordinance, because we wanted to institutionalize this work and really make it law.
Everybody feels like it's time for government to take the lead to call it out. So as we come out of this COVID-19 crisis, we actually have to come out of this better than we went in.
I believe part of the challenge is going to be making sure we stay at the table and stay actively engaged and know that this is a marathon and not a sprint. That the work that we've accomplished on yesterday, I may not be able to see the full benefit of it, like Dr. King and Malcolm X and Medgar and our other heroes were not able to experience and enjoy some of the things that we're enjoying. But I believe my grandchildren, my unborn grandchildren and great-grandchildren, and others will benefit off of the work that we started yesterday.
We need to do more and stay vigilant, as the last gentleman spoke. So we have one final video here. Why are some US cities declaring racism a public health crisis? And I think we've had a lot of answers to that question through this hour. And so we will close with this video now.
In July 2019, Milwaukee became the first city to declare racism a public health crisis. And almost 1 year later, dozens of other cities have begun to follow suit in response to the protests ignited after Minneapolis police killed George Floyd. If it seems surprising that we're talking about this on SciShow, well, there is science here. In addition to being a serious social issue, racism is also a serious challenge to public health. It affects the well-being of people who are subject to racism in every way, including physically. And this is what we're going to be talking about in particular here. In the US, there are significant health disparities between groups of different races, with some of the largest gaps being between white and Black people. And it's maybe worth emphasizing that these racial health disparities are not rooted in biology. All humans are over 99.9% genetically identical, and even those differences that are in the 0.01% are not determined by race. So while people of different ancestry are occasionally predisposed to one disease or another, study after study has refuted the notion that this could account in any way for the health disparities we see today. And that has a lot to do with systemic racism, the type of racism that's built into the fabric of society through laws and structures that promote and sustain racial inequality. And it's important to note that systems of oppression can build upon each other to the point that they become hard to recognize, especially for the communities that benefit from them. And that's often the case, even though in countries like the US, they've been in in place since the founding of the country. But whether or not we recognize it, systemic racism leads to racial disparities in practically everything that impacts well-being, like access to nutritious food, healthcare, and quality schools. It also leads to pervasive discrimination from law enforcement officers, clinicians, employers, and others, many of whom have been trained and educated in racist systems. And all these things have an enormous impact on people's health throughout their whole lives, even when it is not obvious. But systemic racism is often compounded by individual discriminatory incidents, like when a person gets harassed or treated poorly at a restaurant or unfairly dismissed from a job. In situations like these, where a person is aware that they are being mistreated because of their race, that can also have a significant health toll. And that's mostly what we're going to focus on here. In 2019, a study in the journal Health Services Research looked at 29 literature reviews and meta-analyses on self-reports of discrimination, and it found that perceived racial discrimination is linked to mental and physical health in all kinds of ways. People who experience it have higher rates of sleep problems, cardiovascular disease, and premature births, as well as higher levels of stress hormones like cortisol. And systemic racism is part of that. Things like unequal access to resources and constant discriminatory treatment by institutions account for a lot of health disparities. But scientists don't think that's the whole story. That's because having discriminatory experiences is stressful, and stress can wreak all kinds of havoc on the body. Again, it's definitely hard to tease that apart from the stress of systemic racism, but some studies have tried to address that by getting really specific. Like in a 13-year study published in 2020, scientists looked specifically at how hypertension, or high blood pressure, related to rates of discrimination. The survey began in 2000 with a group of nearly 2,000 participants living in Jackson, Mississippi, who did not have hypertension at the time. At the beginning of the study, researchers conducted a standardized survey about racial and other forms of discrimination they'd experienced over the course of their lives. This included experiences they'd had in public places, at school or work, or in receiving services, housing, or other resources. Those who reported medium or high lifetime discrimination were up to 49% more likely to eventually develop hypertension. And it's not just Mississippi here. Other studies conducted in various geographic areas also suggest an association between lifetime racial discrimination and hypertension among specific ethnic and racial groups. These are just associations, so they can't prove that perceived incidents of discrimination cause hypertension. But there are plausible explanations for why that would happen. For example, experiments in which Black subjects were exposed to racist content or situations have shown an immediate rise in blood pressure. Researchers think that the stress response of these situations triggers the body's fight or flight response, so the brain releases a surge of stress hormones, which cause the blood vessels to constrict and the heart rate to jump, creating a spike in blood pressure. Combined with the forces of systemic racism, which come largely from institutions and policies, these experiences add up over time, and they've been linked with things like chronic hypertension and other health conditions. Researchers haven't figured out exactly how these chronic conditions develop, but some evidence suggests that the stress of racism repeatedly triggers the body's stress response system, known as the hypothalamic pituitary adrenal axis. And while we don't know exactly how, some researchers think that this repeated triggering can have long-term consequences. In addition to effects like these, racism may also bring about long-lasting changes in people's blood cells themselves. That's because the release of stress hormones can change the expression of genes in your cells. Gene expression happens when an enzyme reads the genetic information in a gene and uses that information to build a protein, and that protein produces a certain trait. But depending on a bunch of different factors, genes can either be expressed, where they build those proteins, or suppressed, when they don't. In this case, stress hormones can cause cells to express genes involved in inflammation. They can also make the cells suppress genes that help fight off viruses in order to divert energy to immediate threats. Unfortunately, while inflammation can be helpful for the body to heal from injury and fight off infections, when it's ongoing, it can do more harm than good. Like inflammation can cause swelling of airways, which makes people more susceptible to asthma attacks. It can also cause plaque lining the walls of blood vessels to break off and form blood clots, which can cause heart attacks and strokes. Now, racism, of course, isn't the only kind of stress that can cause these reactions in the body, but in 2019, the authors of a small study in the journal Psychoneuroendocrinology looked specifically at the link between these effects and racism. They found that racial discrimination was associated with higher levels of inflammation in Black versus white participants. And separate studies have found that inflammation caused by racism seems to play a role in many racial health disparities. The exact mechanisms aren't always clear, but it has been linked with disparities in overall cardiovascular health, preterm birth rate, and even chronic pain. You may sense a pattern here. The impacts of racial discrimination aren't just short-term. The experience of racism in childhood or adolescence can affect people in many different ways over the rest of their lives. Some evidence even suggests that those effects can be passed down. When someone is pregnant, their stress can take a toll on the developing fetus. Stress hormones can even pass through the placenta to the fetus. The result is potentially a vicious cycle. Health conditions in the womb compound lifelong effects of racism and can affect people's health for generations. But researchers have emphasized that while this type of intergenerational trauma is one factor, external factors like cycles of poverty caused by systemic racism take an even bigger toll. So from discriminatory treatment in systems to the effect of stress on cells, on every level, racism causes and perpetuates the massive health disparities in this country. And this is why, after centuries of racism, cities and counties all over the US are now declaring it a public health crisis. It's a small step, and governments aren't the only ones responsible for perpetuating or solving racism, but it is a step. Thank you for watching this episode of SciShow Psych, and thank you to our patrons who make videos like this possible.
So there we complete this video. Why are some U.S. cities declaring racism a public health crisis? And I think that's really what needs to be done, because once we can bring it to the surface and start to deal with it as what it is. There we go. I'm back. So I understand we have a little bit more time. And, so I did have one other, if you want to see another just 2-minute thing, I do have with Angela Davis, if you're familiar with Angela Davis. She was on Democracy Now! Recently, and she just called it. She just called it. And it'll circle back to where we started this conversation about racism, the connection between racism and capitalism. Mm-hmm. So hold on to your hat. She's just a brilliant, brilliant woman.
Can you talk about racism and capitalism? You often write and speak about how they are intimately connected and talk about a world that you envision.
Yeah, racism is integrally linked to capitalism. And I think it's a mistake to assume that we can combat racism by leaving capitalism in place. As Cedric Robinson pointed out in his book, Black Marxism, capitalism is racial capitalism. And of course, to just say for a moment that Marx pointed out that what he called primitive accumulation, capital doesn't just appear from nowhere. The original capital was provided by the labor of slaves. The Industrial Revolution, which pivoted around the production of capital, was enabled by slave labor in the U.S. So I'm convinced that the ultimate eradication of racism is going to require us to move toward a more socialist organization of our economies, of our other institutions. I think we have a long way to go before we can begin to talk about an economic system that is not based on exploitation and on the super exploitation of Black people, Latinx people, and other racialized populations. But I do think that we now have the conceptual means to engage in discussions, popular discussions about capitalism. Occupy gave us new language. The notion of the prison industrial complex requires us to understand the globalization of capitalism. Anti-capitalist consciousness helps us to understand the predicament of immigrants who are barred from the U.S. by the wall that has been created by the current occupant. These conditions have been created by global capitalism. And I think this is a period during which we need to begin that process of popular education, which will allow people to understand the interconnections of racism, heteropatriarchy, capitalism.
So with that, I think we are complete. Thank you everyone for joining us.